Hello everyone, I hope you enjoyed yesterday's webinar on injury prevention strategies for the foot and ankle joint. Today we're going to discuss the knee joint and we're going to discuss potential causes to anterior knee pain. The first cause can be patellar tendonitis, so inflammation of your tendon just below your kneecap, and also discuss tracking issues related to patella. And there we'll have to have a look above the chain, so around the hip joint, and also below the chain, so similar to yesterday, looking at similar exercises to what we discussed. So let's have a look at my friend here again, Indiana Bones, and let's have a look at that knee joint. Okay, so the big long bone is the femur, and the one we discussed a little bit yesterday, the tibia, so that meets to make that knee joint. And then we have that patella, also known as the kneecap, and this is called a sesamoid bone, as it sits within a tendon and it's technically floating. Okay, and around this joint, you have a complexity of connective tissue known as ligaments. So there's one here, important to remember, and that's the tibial collateral ligament, also known as the MCL, the medial collateral ligament. And on the opposite side here, you have the LCL, or the fibular collateral ligament. And then beneath all this, you have an ACL and a PCL. So your anterior cruciate ligament, which is the Oscar injury for footballers. When you get that, unfortunately, you're going to be out for a long time. So that was the connective tissue. Now we're going to look at the muscles. So the rectus femoris, okay? So that's a big, strong, powerful muscle in your quadriceps. Here is kind of a little bit inaccurate in the fact that we do actually have a tendon which comes from the patella. So from the bottom of the bone here onto your kneecap, that little bony bit, which is called your tibial tuberosity. Some people, as they grow up, they get growth-related pain there. So if I actually just put on the connective tissue again, you'll see this bit here, and it's labeled patellar ligament. Some people call it ligament, some people call it tendon. It does the same job. What we need to understand from that is actually the quads work a little bit like a lever. So similar to a crane, really. So how it's picking objects up, that's how it extends your knee. So as I discussed a minute ago, looking above the chain, so looking at the hip joint, often get patients asking, why are you giving me glute exercises to do or anything to do around the hip, which isn't correlated to the knee? And that's where they're wrong. And it's our job to try and educate or explain in a concise manner how treating up here is relevant to treating down here. And that goes back to that first thing I mentioned about tracking issues. As you can see, this big gluteus muscle here actually has an attachment here to what we call the tension fascia lata and the ITB. So that's that running related injury. People always complain about their ITBs tight or they're getting pain on the outside of the knee, potentially due to some friction happening at this joint there. So that's where a thorough physical assessment done by a qualified physiotherapist would be able to assess your joint range of movement to tailor a rehabilitation program to you to help improve your knee pain. So that was an overview of the anatomy, which I wanted to give to be able to provide an understanding of why we're going to do some exercises around the hip joint when we're trying to prevent knee pain. So what we're going to do now is we'll hop on downstairs and go through some mobility and strength work.
Starting with hip mobility with a couple of basic stretches. This is the well-known pigeon stretch. Adopt this position and hold between 20 to 30 seconds and repeat on the other side. The deep gluteal muscles here, called the piriformis, can be targeted by laying supine, bringing one leg up towards you with the other leg across, and again holding between 20 to 30 seconds. This one's an active mobility stretch for the hips, where you're dropping into internal rotation by dropping the knee in. Repeat 10 to 15 repetitions on each side. A little bit more advanced now is this squatted technique, where similar to the exercise before, you're dropping that knee in and back and repeating 10 to 15 times each side. This one here now is going to some strengthening work, working on co-contraction of the adductors, so the inside muscles of your thigh, and also the glutes coming up into a bridge and squeeze. Use mild resistance like a ball or a cushion. This one's a little bit more advanced, but I really like it. So it's working on single leg stability of the left leg, but also then the right leg needs to be at a right angle, pushing against some resistance like a ball against the wall. That's working the glute med, which is an important external rotator of the hip. This is a nice introduction to isometric exercise, where you're still strengthening the muscle without actually it changing length. So you're pushing out with the right leg, equal force to the one you're flexing down with the left leg. Another isometric exercise is this wall sit, which you'll all probably be familiar with. Here you're not obviously putting much load through the knee. However, if you come down to a lower angle, this increases the load to the tendon. Also, you can add a weight as well to add more resistance and strengthen the glutes and thigh muscles. If unfortunately you're already experiencing some pain to your knee, you may be familiar with this chart. Often physiotherapists use this to measure the severity of your pain. However, we also need to know the pattern, so when you're getting a pain, if it's related to certain exercise. Therefore, we use something called training load measurement. In order to measure your training load, I ask my clients to rate between 1 and 10 on how difficult they found each exercise they did. For example, if you went running one day and you found it very hard, you would put about a 9. In order to measure your training load, I ask my clients to use a training diary. This is an efficient way for myself as a therapist to understand what exercise you're doing, how hard you find it, and then understanding how much that is contributing to your symptoms. For example, in this diary, they've recorded activities including CrossFit and running, as well as doing a weight session at the end of the week. You can see here that the most symptomatic exercise is CrossFit. This is where it's really important for myself as a therapist to understand my patient and their goals. So if they were keen to do the CrossFit training, I need to look at what the load they're doing before. So in this example, with the high intensity interval training and the running, we know that's probably putting a lot of load to the knee joint. So here I would ask them to adapt their HIIT session, so they may be including more upper body, and also on the Friday before, maybe doing an upper body weight session. Or if they were a keen runner, maybe they still do reduce the HIIT session and replace it for something like upper body weights again, to allow the muscles around the knee appropriate rest.
So there you have it. I hope you found that useful. We obviously covered a lot of anatomy and we discussed some exercises in preventing knee pain, and we focused a little bit on the hip mobility and hip strengthening and how that can affect the knee joint itself. So the rest of the week now, I'm going to be planning some videos based around ergonomic assessments and providing those who are working from home now and these unprecedented times, just a little bit of advice on how to have your workstation set up and some strategies to stay active. I look forward to seeing you all very soon. Thank you and goodbye.